So today we have Dr. Siri, who is an emergency medicine doctor. So as per the polls, we decided to do ultrasound that too in COVID-19. So let's give it off to Dr. Siri, and thank you, Doctor. Continue, please.
Hi everyone. I'm going to share my screen so that my name is Dr. Siri Chamardi. I work in Europe. We've been through a lot this past year with COVID. All right. So I wanted to I got a lot of questions through the channel from you guys about the use of ultrasound, especially during this time during COVID, and when we should use it, why we should use it, how we can distinguish different pathologies on ultrasound, especially in relation to lung ultrasound. Ultrasound is a really useful tool to have at bedside because you can immediately try to make a diagnosis or figure out what's going on. So I thought it would be interesting to go through this article because it's actually very comprehensive and answered a lot of your guys' questions. So this article came out of Europe, Gargani et al. I believe they were based out of Italy during the very first search. And it's why, when, and how to use lung ultrasound during the COVID-19 pandemic. So it's very challenging for physicians to provide an early diagnosis, kind of isolate patients, and especially in places like that are not as well equipped with less resources. So I think it's important to be able to use all the tools that we have, including ultrasound in this stage. So study aims. So this paper basically was trying to see okay, there's certain CT findings that correlate with COVID-19. As we all know, bilateral peripheral gland glass opacities correlate with COVID-19. However, there is a lower sensitivity for a real-time PCR and other tests that are out there. Even in America, like the tests that we have, sometimes they're only 70 or 80% sensitive. So, it's really important that we can actually use an adjunct like ultrasound in these settings. So how can it be used? So this is kind of interesting. There are several clinical scenarios where ultrasound can kind of help you, and it can be used in different stages of a patient's, I guess, like where they're at. So at home, if there's any available, like portable ultrasounds, or physicians are doing home visits, you can kind of do a quick assessment. In the emergency department, it's very often used in America. It's like every emergency department will have an ultrasound, so we can use it quick and at bedside. It's more sensitive than a chest x-ray, especially for looking at certain findings such as lung sliding. And it can actually help you differentiate causes for dyspnea. Dyspnea is a fancy term for shortness of breath. So it can help you differentiate these causes. Unfortunately, there are some overlapping patterns, but we're going to go through some of those patterns in a little bit. In the internal medicine, so in America, every doctor is pretty subspecialized. So the internal medicine doctors are the ones who take care of patients in the hospital after they are admitted by the emergency medicine doctors. So these are the gatekeepers, and then the IM doctors are the ones who really take care of them throughout their course of stay. So, say as patient is at the hospital, day 3, day 4, start to develop increased shortness of breath or something like that, then you can actually go and you can do an ultrasound at bedside in order to see, hey, has this patient's clinical status actually changed? Because I know it's not easy for all places to be able to get a chest x-ray all the time, like every single day, like we do in some hospitals in America. However, it is easy to take this machine that's very portable, and you can quickly look and be like, oh, that looks different than yesterday, or that looks, I don't see lung sliding. We need to intervene and kind of immediately kind of anticipate clinical deterioration. The ICU, the very special place for a lot of the very, very critically ill patients. With relation to lung ultrasound, there's a lot of utility in the ICU as well. It's quick, it's it's also dynamic, like we were changing. If someone's condition changes, they suddenly are becoming very hypotensive. You see tracheal deviation, or that your PEEP is too high on your machine or something, and you have to go ahead and consider that maybe you popped a lung, and there's something else going on. So there's a lot of different uses for ultrasound in these different settings, both clinical and at home. And I think that that's why talking about lung ultrasound itself is actually really important. And I'm glad we're doing that right now.
We don't use it actually ultrasound most commonly. We use HCA only every day. We have like that only.
X-ray, right? So X-ray, each time you get an X-ray, there is a radiation risk. And
Yeah, it is there.
yeah, so there's a principle that I'm going to teach you guys about. It's called ALARA, ALARA. And what it stands for is as low as reasonably achievable. And this is a principle in radiography and ultrasound and essentially radiology that says, how can we minimize radiation exposure to the patient? What is possible for this patient? How can we achieve a diagnosis with using as least amount of radiation as possible? And that's the principle, ALARA. And so ultrasound is super useful in that setting because there's no radiation. Ultrasound is a form of, it's essentially using electromagnetic principles. And while using those principles, you do generate thermal energy, especially when you use color Doppler or Doppler. So there are some uses where you should be a little bit more cautious, such as doing a Doppler study of babies in the mom's uterus. If you're doing that, there is some thermal index that says, hey, listen, you could potentially cause harm. Or when you're looking over the eye, if you're using thermal energy, you could cause some damage. So those are the two potential areas where it's really like, oh man. But if you're ultrasounding the arm or something, no one cares if it gets a little hot. It's not it, or the lungs or the heart. Overall, it's very low risk, and there's no radiation risk, but there is a thermal index that people should be aware of when they're using ultrasound. So breaking down kind of the uses of ultrasound, like we said, in the emergency department where I work, we're trying to find the people who have COVID, kind of identify them as soon as possible, and then get them to treatment, either home or in the hospital. In the hospital itself, in the wards, maybe looking at how severe their disease is with an ultrasound can help you manage the patient further. In the ICU, again, you can manage the disease progression, kind of the dynamic way that ultrasound findings look, especially if they're on a ventilator, because it's hard for a patient to tell you, oh, I'm feeling worse, if they're in a coma with a tube in their mouth. It doesn't work that way. And at home, you can look at clear positive versus negative findings of lung ultrasound. Like if you, for people who use ultrasound at home, it's really like, oh, okay, you have COVID or you don't have COVID. You're not trying to classify oh, you kind of have some mild COVID. Oh, actually, you have very severe COVID, but you don't look like you do. It's not like that. It's like, oh, you have COVID or you don't have COVID. That's what people at home should, if anyone owns an ultrasound, should really be doing. Okay. So I got asked a question about the Blue protocol. And I think that was one of the things. So there is many ways to kind of go through a systematic sort of approach to identifying different pathologies of the lung. And the Blue protocol is one of these protocols, essentially. It's a diagnosis of acute respiratory kind of failure and how we look at the lungs. So I just want to say, for this particular paper that I'm going to go through, this is a very, whatever you do, if you use the Blue protocol, use it, whatever you call it, but as long as you're going through whatever exam you do on a patient systematically every single time, then you will miss less things. And that goes for things like ultrasound as well. So we try to look at different areas of the lung very systematically. And I may do it differently than you. I may always start on the right. You may always start on the left. I may always start in the front. You may always start in the back. It doesn't matter. As long as you click check, check, check. I've looked at these areas as much as possible. I've actually taken a look at all the areas. That's what's important. So for this particular paper, they said, hey, let's look at the front, let's look at the side, the axillary area, and let's look at kind of like near the back, and then let's look at two kind of regions of the back, both more lateral and more medial. And that's where they got all of these numberings essentially. So they've kind of, for this paper, they looked at kind of a thorough look at the whole heart to try to distinguish different pathologies, which we'll lay out to you. Just to keep in mind, there are proposed theories of different types of COVID, which we have also seen in real life. There's the kind where you might not see that many radiologic changes. However, the patient just looks like terrible, probably from the cytokine release and everything, and they might, require more intervention. And then there's kinds where some patients, you see all this like shit in their lungs essentially, and they might get better sooner. Who knows? We still trying to figure out all the nuances of this disease, but just keeping in mind that COVID can look different and that there are different kind of presentations are really important, even when looking at an ultrasound, because not all COVID ultrasound looks the same. So let's just talk about kind of comparing. So this on the right-hand side is CAT scan, and then this on the left-hand side are ultrasound findings that correlate with the CAT scan. And I thought this image was just really telling for you guys, because if you see like here, this is a relatively normal ultrasound. I don't really see anything crazy going on here. But here, when you look at even the pleural line where your visceral and pleural line, like kind of it's very thickened. Visceral and parietal pleural connect, it's very thickened, indicating infection. So here you could see it doesn't look that bad, but as the kind of disease progresses to this very diffuse pneumonia, bilateral, multilobar, you can see here you have air bronchograms, fancy term for small areas of consolidation within the lung. And also you have the texture of the lung right here looks very similar to the adjacent structure. And this texture and the echogenicity of the lung, it's called hepatization, meaning it looks like the liver, the hepatic system, right? So that term is also used sometimes to describe late changes of like a sort of pneumonia. So these are kind of like the correlates for ultrasound and then CT. Here, I just wanted to point out these hyperechoic lines going all the way down to the end are B lines, and you could see that here you have kind of an area consistent with viral congestion. B lines can be caused by several things. They can be caused by pulmonary edema, or they could be just caused by viral congestion, which here, looks like viral congestion, because the clinical picture, and the clinical picture is that the patient has COVID.
How can you exactly say it is COVID by just looking at the ultrasound?
Well, looking at the ultrasound, we're gonna get to that. That's why we haven't gotten to that. Okay, so there, this particular paper looked at looked at kind of aeration scores. So looked and said, hey, look, doing this lung ultrasound that's very thorough, how can we assign a number, like an objective thing to this particular scan, so that we know how bad a patient's lungs are, and we can just compare numbers instead of saying, it looks fine. Oh, actually, maybe worse than the last one. Oh, okay. You can objectively say, oh, this patient's lungs are at a score of 8, and this other patient's lungs are at a score of 6. So it's like an objective kind of comparison, which was kind of interesting as well. So here you were asking, I'm going to go through this one by one. So this actually compares different lung ultrasounds that we commonly see and how they are different from each other or how they present. So the first kind of very, very common presentation we see in the ED is cardiogenic pulmonary edema. So, okay. Cardiogenic pulmonary edema is basically like a fancy way of saying like heart failure. It usually causes pulmonary edema. Shock can cause pulmonary edema. Usually these, the distribution of pathology is very homogeneous, meaning like it's not just one line isn't really distinguishable from another. They all look the same. And usually they're separated or coalesced. So here you see B lines right here, and they're very thin. This is like one coming off right here. It's very thin and it goes all the way to the end. So you might see some compressive atelectasis because cardiogenic pulmonary edema means that your lungs are filled with fluid, and sometimes they can accumulate into a pleural effusion. And that pleural effusion can push on your actual lung tissue and collapse that tissue so that it causes that atelectasis. Usually you don't really see a lot of consolidations. And if you do happen to stick a needle in that lung and pull out some fluid, it's going to be transudate, not exudate, if it's related to your heart. And then usually the pathology that you're going to be seeing, because it's related to heart failure, is bilateral. There's not going to be as much of a side preference versus in infectious kind of pneumonia or other things. There might be a side preference because it's selective versus this is just distributive. So this is what cardiogenic pulmonary edema looks like. This is kind of more the classic picture. Okay. ARDS. So ARDS was thought to be like kind of the end stage like presentation for COVID-19. COVID-19 that's very, very, very like severe. But it by itself, prior to this disease, this is what it looks like. You can have irregulation fragmentations of your pleural line. So here you see how it's not a smooth line. You can have B lines coming down. You see like this lung itself, it's a very hyperechoic compared to the lungs that we're seeing in the past, indicating that there's probably more like patchiness. It's kind of like a non-gravity related distribution, like I said, patchy. You could get some small consolidations, but usually you don't get really large consolidation unless you're actually acute respiratory distress is caused by infection, which is why I said COVID-19 can cause this at the end of the day. But when I think of COVID-19, this is not the classic picture that I'm thinking. And usually it's not as large. Even if you have a consolidation, it's here, it's right, it's very small. Bacterial pneumonia. So a lot of COVID-19 has superimposed bacterial pneumonia because, you know, infection itself makes you more susceptible to more infection because you have this huge release of cytokines and whatnot. So you can get some focal interstitial syndrome, meaning you can get some small areas where you see these B lines coming down. But here I want you to notice this tissue is not as hypoechoic as the one I showed you prior. So it's not like the ARDS picture that I'm showing you. It's different. It looks different. And then you see these small areas right here that are kind of where those bacteria accumulate within your lung tissue. And you could get some tissue-like accumulation secondary to bacterial pneumonia, because what you get when you have a bacterial pneumonia associated with a pleural effusion, that pleural effusion is called an empyema because it's suspected to be pus, right? So it looks different than the plain Jane, like very anechoic area of your lung. And it's usually not very large either because the bacteria likes to take over, and instead you have a lot of pathology within your lung and less pathology outside your lung, usually. Okay, chronic interstitial lung disease. So these are patients who have kind of lung disease at baseline. We're talking like pulmonary fibrosis and whatnot. Like this is their lungs at baseline are different. They're not the same as you and me. So usually it's more prevalent at the lung basis, although it is kind of distributed kind of equally on both sides because congenital disease doesn't really, or even acquired disease doesn't really sort of distinguish like that. Separated B lines, sometimes you can get some B lines, but here you see that pleural line is very different. It's discontinuous. And there are usually no spared areas. That's really what's important. Like if you have a patient with silicosis, for example, there's not really going to be like, oh, they're not going to be like, oh, we're not going to choose that upper area of the lung. It's not going to be like that. It's going to be like, oh shit, I'm inhaling all this like substance and it's going everywhere within my lungs without sparing any areas. And then sometimes, very, very rarely, you can get a pleural effusion. It's not very, very common at all. And then usually if you have a effusion, it's not very large. Here, it's like right here, if you even have it. And it also doesn't look like COVID. So COVID, like the way we can distinguish it on a lung ultrasound also depends on our clinical picture. Like, if we have a patient with CHF and COVID and we see multiple B lines, I'm going to treat that patient for both CHF and COVID because I'm not going to be able to say, oh, these B lines for sure are COVID. It's not like that.
It's not specific.
But it's but what we can say is that if we have a patient who at baseline doesn't have any of these diseases, then there is going to be a difference in these sort of findings. So finally, we come to COVID-19 pneumonia, which very patchy distribution. This is going to look most similar to bacterial pneumonia because usually you have some superimposed bacterial pneumonia. Here, your pleural line isn't very distinguished at all. You see a lot of fragmentation, like it's infected essentially. There is like kind of a light beam that goes through. It's more hypoechoic in general. You can get B lines that coalesce into a waterfall sign at times. And you can get some peripheral consolidations. Usually they're smaller than bacterial pneumonia. Bacterial pneumonia the actual consolidations can get really, really big. With COVID-19, the virus is already taking over most of your lung. So it tends to be that they're less big in general. And if you do get a pleural effusion, larger ones are very rare. But small ones are very present and can even accumulate all the way up to the apex of the lung. So this is kind of how they differ. I think I included an image at the beginning, like how you can compare all of these figures just for your thing. But this whole presentation is based on a paper, which I really encourage you guys to read to kind of get all of the nuances of what I was trying to say. So limitations of using lung ultrasound in COVID-19, there's no robust evidence, meaning we still haven't validated like, oh, there's no like lung ultrasound score that's like internationally validated or nationally validated out there. It all depends on who's using the lung ultrasound. I might see something different than you might see. A medical student might see something different than someone who uses ultrasound every single day because it's all very user dependent. And the last thing is, we're still in the middle of a crazy pandemic and a lot of people still have not yet to receive the vaccine. And so there is a high risk of exposure, especially if you don't know what you're doing and you're spending a lot of time. So just kind of being wary and when used by the right people at the right time and with the right clinical mindset, like with the clear picture of what you're trying to get the answer to, it's very useful, but there are limitations. And then takeaways from this is basically that it could be used in different settings, and you really need to use your clinical gestalt. Like if a patient If you also cannot substitute ultrasound for a stethoscope. A stethoscope is still going to be your window to the lungs. If you hear crackles, you can take the ultrasound, you can look at it, you might see rails, you might not see rails. Hey, but listen, if you hear crackles and you don't see beeline, sorry, it could be COPD too. Like you still have to use your clinical clinical knowledge in that setting. So that's basically like my presentation you had left.
So have you ever seen the mechanical effects in your?
I don't know what this is really. So clearly I haven't seen it. Like, are you saying like when you push down on the skin?
Actually, the waves,
I'm
ultrasound waves goes through the skin. Actually, I
yeah.
read it somewhere. There are two side
Okay.
effects, thermal effect and then one mechanical effect. So is it
Yeah.
theoretical or just?
Yeah. I mean, so here's the thing though. That's why we exercise caution, right? When most of the times, I think these microcavitations you're referring to, I think what you're talking about is in the ocular ultrasound because the skin is so thin, and that's where you can really get a lot of effect on like your lens of the eye because it's the most anterior portion, right? So I don't know much about it other than that because I don't try to use Doppler when I'm doing my eye exam. That's
So how will the management differ? Because we here use CT scan basically for any COVID patient, and here you use ultrasound. So how will the management differ?
we use CT scans too. Ultrasound
We
is
don't use
just
ultrasound.
yeah. So I think ultrasound is going to be the future. Is unfortunately not enough people are first of all trained, and second of all use it enough like that. Because the thing about a lot of we use CT scans and chest X-rays. We use a lot of X-rays to kind of daily X-rays to kind of monitor how a patient is doing. In terms of differing management, I usually do get an adjunct X-ray minimally with the ultrasound. The thing about ultrasound that can help me in COVID patient is that basically there's a lot of prothrombosis in COVID-19, meaning you can get a lot of PEs, DVTs, renal failure, a lot of these different things. So if I'm suspicious a patient has renal failure, I'll do a kidney ultrasound and just, make sure there's nothing crazy going on there. And if I'm suspicious a patient has a PE, I can do an echo in addition to the chest. And an echo will aid me because I can look for signs of right heart strain that would indicate that this patient is having a large PE. I can look in the parasternal short axis and the apical four chamber view, kind of looking at to see how the right heart is doing to make sure that I'm not missing something crazy. And I feel pretty comfortable, looking at that, and also, whatever measurements are needed, you could get a few measurements that'll help you. Like you can get a TAPSE to look at the tricuspid valve, or all these things can be easily done at bedside. So that's how it will kind of change my management. If I usually end up doing for most COVID patients an echo in a chest. The chest will basically, if it's super clean, I don't see anything at all on my chest exam, it's kind of reassuring to me. But at the same time, we talked about how there's different types of COVID, and if a patient is acutely hypoxic to 80%, but there's nothing on the chest, that's super concerning for the other type of COVID, right? The L type that we were talking about. So the management, honestly, it doesn't change as much because you're just trying to figure out, is there COVID or is there not? And we use the rapid PCR to give us a kind of final word, there's definitely COVID. Yeah, so it's a chest X-ray, and that are the main things. And then sometimes a CT scan to look for pulmonary embolism with an adjunct chest and echo ultrasound. The thing that ultrasound really helps me is if I have a patient who I'm trying to differentiate different types of dyspnea, and I can really say, hey, look, this patient doesn't have any V lines. I think that maybe they might just have a plain Jane COPD exacerbation or something like that. But also I still try to, I feel like it would allow me to initiate treatment earlier because of how I implement, like I take it to patients' bedside the first, 15 minutes I'm talking to them. I talk to them, do my exam, and I do the ultrasound, and that's like another 10 minutes instead of waiting 3, 4 hours, 5 hours, 10 hours, 20 hours for their CAT scan.
So you might have known comet tail artifacts.
Yeah, so comet
That
tails are very similar to beelines, but they originate from a speckle, like versus beelines are from the actual edema itself, and they kind of go all the way through. The comet tail can originate even at the middle of the screen because that speckle could be air bronchogram.
that's it. No more questions.
That was all the questions? Wait, so I did answer a lot of the questions with the presentation. I'm
You already
glad.
did.
I think it's easier to visualize. Ultrasound is a very visual thing. So basically, it's easier to visualize it. So if you do have an ultrasound available to you, which I don't know, do you?
Yeah, we have.
Yeah. So I would just go to patients, go your axillary, posterior, minimally, both sides, and you'll have your answer. I promise you, it has never hurt a patient, unless you're don't use Doppler on the eye. But
In our
other than
emergency
that,
department, we have, but we don't use actually for COVID. It's just for use for fast. That's it. Don't use it
no,
for COVID.
you can use it for COVID. It's super useful, and now you can tell the people who run your department why. Why would you just waste a piece of equipment right there? Okay.
That too for only lung we use for tapping, fluid tapping. That's it. We don't use
Yeah.
lung ultrasound. We have
Well,
TB more common.
yeah, TB is really common.
That's
Unfortunate, but TB, you'll have that or right or left upper lobe consolidation, which now you know what bacterial consolidation really looks like. So that's the findings you can look for.
okay.
All right.
Thank you so
Okay.
much.
Yeah. I'm glad it was useful. Good luck. Bye.
Thank you.